Hotbed Talk.
This piece, EBPOM London 2020 Models of Prehabilitation, features Denny Levett, Professor in Perioperative Medicine and Critical Care at Southampton University Hospital NHS Foundation Trust, and Gerard Danjoux, Consultant in Anaesthesia and Sleep Medicine at South Tees Hospital's NHS Foundation Trust, with their guests John Moore, Clinical Director for Intensive Care at Manchester Royal Infirmary and Medical Lead for Enhanced Recovery After Surgery, Professor Sandy Jack, PhD, Consultant Clinician Scientist in Anaesthesia and Critical Care Research at University Hospital Southampton NHS Foundation Trust, and Rachel Barlow, National Lead for Enhanced Recovery, Prehabilitation and Optimisation at Cardiff and Vale Health Board in Wales. It begins with the panel giving a brief overview of their work before they go into questions. Have a listen.
We set up our pragmatic randomised control trial factorial design called Westfit for Cancer Surgery, fondly known as Westfit, which is predominantly translating the HIP training into the community, prescribed by the clinical and the trials team and delivered by personal trainers. So it's the same rigour and fidelity as what we performed in hospital. And this is in patients undergoing intracavity surgery, so the big 5 or 6. We've also delivering psychological support in cancer support centres, and this is all underpinned by behaviour change. In Wessex, we had 10 gyms open and we had 6 cancer support centres, and we'd also opened, I'm delighted to say, Plymouth. So before the lockdown was announced, we paused Westfit. I was completely devastating effect on the 9 patients we had to ring up to tell them they could no longer take part. And it was a significant call to arms that I text June Davis, who you've already heard from, who's leading the Macmillan guidance, with Mike Grocott. And we were able to translate Westfit into a virtual clinic, delivering what we thought were universal interventions. But in some contexts now, we think it may be soft-targeted. It's in partnership with Macmillan Cancer Support, Wessex Cancer Alliance, and delivered by Can Rehab personal trainers, the level 4 personal trainers. I'm absolutely overwhelmed by the support we've had from the Royal College of Anaesthetists and the Centre for Perioperative Care and various other people supporting us. It delivers multimodal interventions, including diet, healthy eating, exercise, physical fitness, and psychological support, emotional support. And we've been overwhelmed by the amount of people that have signed up via our self-referral.
So we might touch a bit more on the safe fit, which you were describing at the end there as part of the questions, if that's okay. Rachel, could you give us a brief overview of your work?
My presentation focused on 2 elements of innovative prehab models. One being the long-awaited primary care optimisation prehab journey, starting the process of optimisation at the point of suspicion of cancer in primary care. A huge amount of work has taken place to get to this stage in terms of governance around primary and secondary care data, sharing agreements, measurement, but also most importantly trying to make the process as simplistic and as time effective for primary care colleagues. The other approach has come to fruition at the outset of COVID-19 pandemic, when essentially elective surgery was ceased. Certainly in Wales on the 16th of March, and obviously just slightly after across the UK. We wanted to make sure our patients on the waiting list felt supported, but also really importantly not forgotten. We are using an innovative, nudging, behavioural change approach for prehab style information for patients on the inpatient waiting list. I'm glad to say that's just both elements of work have just been endorsed by Welsh Government last week for rollout. And as I say, we are due to go live with our nudging today. So we'll be nudging 4,500 patients on the inpatient waiting list. Cardiff and Vale Health Board and Swansea Bay and other health boards are soon to come on schedule. But to summarise, both of these prehab approaches offer unique ways to maximise the lean-in time prior to surgery and or cancer treatment.
Thank you very much. John Moore, can we have a brief overview of the Manchester work that you're doing, please?
Yeah, so hello from sunny Manchester. As Jerry said, I'm sat outside the hospital. Where I would start for colleagues is to consider 3 things. Why you might want to take prehab, how you might do it, and the what, which is the results of a prehab intervention. I think all the models that we're describing from Manchester, Southampton, South Tees and the Welsh model give lots of different ways of doing the same thing, which is delivering prehab. So I would encourage people to contact us offline and online and say, well, how might I develop my own programme? Because I think within all of our programmes, there's a method for how you might deliver prehab where you are. So how we've done it is we've reached out across the system, which is Greater Manchester, with colleagues from the partnership, which the Devo system allows us to do that, all the partners within the hospitals. I think a big thing for us was realising the power of AHPs and the allied health professionals, which are basically the army, I think, of prehab and rehab, and also the nursing workforce, which a lot of the ERAS processes happen through. And I would encourage people not just think about prehab, but also, as we've tried to do in Manchester, to think about the surgical bit, which is how you optimise enhanced recovery for patients. That then feeds back into prehab, which is the preparation, then into recovery, and then following that, how you institute long-term health change for patients. Our programme in Manchester has delivered that for around 800 patients within the Prehab for Cancer programme. We've looked after those patients over the last 12 months, starting in April last year, and we, as others have described, we had to evolve that programme when the COVID changes happened, and we've managed to do that with a digital telephone support led by Kirsty and the team in Greater Manchester, where those team members were kept within the team, allows us to support upwards of 400 patients at the moment across Greater Manchester. So just to summarise, I think there's lots of different ways of doing it. I think it's really helpful to know what the outcome or the what you're trying to affect. And for anyone trying to do a prehab change, it's understanding what the what is. Is it 2 year length of stay? 2 year survival? Is it hospital length of stay? What's the thing you're going to persuade commissioners of to allow you to make your process be something that's business as usual?
I could just in literally 1 minute give you a quick overview of the South Tees programme, which is also part of the session. So the South Tees programme, or PrepWell, is modelled primarily on cardiac rehabilitation, which, as I'm sure a lot of people are aware, is an evidence-based intervention post-cardiac problems. We're working very closely with public health, primary care, and presently with Sport England. We have a local delivery pilot award through Sport England, which is funding our ongoing work. We have a focus on cancer and non-cancer, and we have some exciting development plans for other groups, including orthopaedic prehabilitation. Our model is community-delivered, community-based, and health trainer-delivered with project management from 2 physiotherapists, Esther and Sam. And our future plans include development of a digital dashboard for patient evaluation and tracking. And we hope to use this in future to close the gap between prehabilitation and pre-assessment. And I think we'll probably touch on that in a minute. We have also supported this by education and primary care colleagues with a primary care toolkit, which some people may have seen. I haven't covered that in my talk. Okay, so I'd like to start with a question for Sandy about her talk. It's mainly around SafeFit. Big congratulations for getting SafeFit up and running in such a short space of time. I think the original conversations were literally being held at the start of April about that. How do I make patients aware in our region about SafeFit? How can they self-refer? And is it available across the whole UK?
Self-referral is via the Macmillan Cancer Support website, and it's a smart survey that people then just fill in some details, and then we have that self-referral, and then there's a process that we then have a conversation with the potential participant, and the CAN Rehab lead does the screening and assessing, and then they match the person to an appropriate personal trainer. So it is UK-wide for any patient with a suspicion or a confirmed cancer diagnosis, but no histological or pathological confirmation. And the only limitation is you have to be over 18 and obviously pass the screening to receive the interventions. But you can just receive one intervention and be part of the service.
So is there some mechanism where the details of how we can participate could be cascaded out?
There's just a link that, in fact, if you just go online and Google SafeFit Macmillan, it comes up. So it goes to the smart survey, but it's on the Macmillan website.
Rachel, I'm intrigued by digital nudging. Amazing effort to get that approved and rolled out. And I'm very interested to know, if I want to do this, I want to start this tomorrow in my institution. I've got however many thousands of patients waiting for surgery. How would I go about that, first of all? And I'm just interested to see how you might ensure patient safety as part of that process.
Thank you, Jerry. Yes, this has been a huge effort to get to go live. And as I say, we're going live today in Cardiff and Vale. Who do you speak to? Well, I suppose the first person I spoke to was our comms director. Really important that comms are central to this approach. And effectively, you need to build a team. So the operations director, whoever is responsible for managing your waiting list, your RTT times and performance side of things, but also speak to your information department, because you need to be able to identify who by speciality is on that waiting list. And obviously the waiting lists change daily, weekly, so it's a case of a dynamic process and how we manage that and mitigate errors and concerns, which links in with the concerns team, the patient experience team, and obviously with your health records department, the people who are responsible for communicating appointment times, etc., with patients. That's from the process side, but obviously we have to develop the content to nudge patients with. So your public health colleagues, your primary care colleagues, allied health professional colleagues, exercise colleagues. It's been a real team effort, but obviously what we have now is a major effort to communicate health messages to patients at a time when they are potentially anxious. We don't know as an NHS when the recovery is going to hit and whether we're going to have a second spike. So we are able to send direct communication messages to all patients on the waiting list. Picking up on your second point, this was signed off at board level within the health board. In Cardiff and Vale, we have health boards. Well, in Wales, we have health boards. Also, we've had to engage with our local medical council, so local medical committee in terms of primary care, because one of the concerns was around if you're notifying patients about behavioural change, will they default back to their primary care practitioner? Because we've got the primary care prehab work starting, we've got a very strong relationship with our primary care teams as well. So we have been working in partnership on a letter which goes out to all patients on the inpatient waiting list, explaining the process, the safety concerns, who to contact if they're not sure, but most importantly, we haven't spelt it out, but encouraging patients to come through the secondary care system rather than defaulting back to primary care.
I've got some questions coming. I think there are several themes appearing in this, and I think one of the first, and there's a lot of questions around this, is the funding for prehab, because I think a lot of centres, both nationally and internationally, are struggling to get a business case together to commission a prehab service. I wonder if we might just go around all of the speakers just to clarify what your source of funding is currently and any particular challenges you found in attaining that. And whether it's also long-term funding, as in permanent, or whether this is a pilot service to be evaluated as yet.
So Westfit is funded by NHS England as a Cancer Transformation STP and supported by Wessex Cancer Alliance and other alliances. SafeFit is interesting because we set it up extremely quickly and we had some pump priming from Macmillan Cancer Support. Wessex Cancer Alliance are supporting it with the resources from Westfit, and we're supporting it with some of our resources. We've applied for various funding from different sources. It is not a sustainable model as yet. We need to have the conversation with NHSE and I to discuss whether this could be funded by them. But I think the main message from the alliances and NHS England are that, well, all the money sits at the end of the pathway in stratified pathways. So this is after they have treatment. We need to pull all of this forward because then there'll be less money needed to be spent at the end of the pathway.
Thank you, Sandy. Any idea of an approximate cost per patient of Westfit and SafeFit? So just to give people an idea of the cost of the programme.
So SafeFit is at £326 per patient. That's to support them over a 6-month period. And Westfit's pretty similar if they're on a very short pathway of only 3 weeks or 2 weeks before surgery. It's in the thousands if on the 15-week pathway, which was what patients wanted to have Westfit and the interventions during the whole of their neoadjuvant treatment. Excellent. So really quite cheap.
Yeah. Rachel?
Okay, so it's quite different because we have integrated health boards here in Wales, which cover public health, primary care and secondary and tertiary care. We have, within Cardiff and Vale, a recurring fund for prehabilitation, which includes the primary care aspect. Obviously, with COVID, we were due to go live, as I say, in April. I'm waiting to have confirmation about whether our allocative budget is still in the bottom line. I'm reassured that it is, but it's got to stretch across the whole pathway for all patients. So, we're looking at innovative ways to, obviously, this is not a pilot service. We've done piloting, we've done research. This is about a sustainable service for patients going forward across the whole patch, and also linking into population health and preventative medicine as well. So as I say, we have got a recurring pot of cash. What that translates to, we're still working through the detail. But one of the things that's come to light as a result of COVID is how important prehabilitation per se, particularly around the primary care and the nudging, is for recovery plans for health boards. I had a call yesterday with the Director of Primary Care in another health board. We spoke to Welsh Government last week, and we're looking to see how this can be funded through what's called a direct enhanced service, or a DES. That is quite complex in terms of primary care because it's got to be approved by the BMA, the College of GPs. It's a very complex process, but what I can say is that we certainly have our GP colleagues, our primary care colleagues primed now to deliver this work at the outset of the patient's pathway, both for cancer and non-cancer patients.
John, could you fill us in a little bit on the funding pathway in Manchester?
We received an innovation grant of £1 million to put 2,000 patients through the Prehab for Cancer programme, which works out as £500 per patient. So actually, relatively cost-wise, an efficient way of getting preparation and recovery for patients around the community gyms in Greater Manchester. I think the opportunity piece with COVID, although it sounds slightly the wrong way around, is that actually people need to spend less time in hospital because you don't want them to acquire COVID as a complication of being in hospital. So I think ERAS, surgery school, prehab has got this opportunity, but we need to persuade commissioners of that and for them to understand that. So in Manchester, what we're trying to do is bundle together enhanced recovery and prehab, surgery school, all as one bundle of care, so that patients can take advantage of that. It's very much, as Rachel was saying, around what we're trying to do with nudging in Wales. It's patient education, preparation, but giving them the ability to get fitter and stronger both before and after surgery. So I think for commissioners, if you can show to them that actually this will result in a reduction in length of stay and complications, that probably makes sense at a time of COVID, although we are going to find it very difficult with COVID funding at the moment, or lack of for other things, to keep pushing prehab up the cancer agenda. So I think different ways of doing it, but I would try and push bundles of care together.
Thanks, John. And finally, Jerry, for the PrepWell programme.
Our initial pilot service was funded by the Health Foundation. I was working at the time with public health and primary care, a bit like Rachel, and we simultaneously put a bid into Sport England for one of their prestigious local delivery pilot awards, which we were lucky enough to get. That's a much broader agenda than just pre-rehabilitation. It's about increasing physical activity and exercise in deprived areas and in communities. So we have about 5 different programs going on, or work streams within that local delivery pilot. But one of those is that we've got funding for the next 3 years to develop and evaluate PrepWell from where we are presently. But the sustainability will depend upon creating a sustainable case, of course, if we're going to convince people in the future that the service should be commissioned.
Sure. So interestingly, as everyone said, slightly different models with prehab across the United Kingdom, and I'm sure if we looked at programmes internationally, the same would hold. I think this really also reflects, there's a lot of questions about if it was mandated nationally, it would be easier to get uptake. But I think one of the challenges is that the evidence base is lagging our enthusiasm to some extent. And the really important thing about these programmes we've heard of from certainly the members in the audience today is that the data is being gathered. And I mean, the early data that you've reported, John, suggesting, effective changes in fitness, and you, Jerry, that the behaviour change was sustained, because it's not just the short-term outcome from surgery, it's also if we can sustain the behaviour change, managing to show that patients have long-term changes in exercise and nutrition behaviour, which would affect long-term health outcomes. Moving on, there's also a lot of enthusiasm for a question, and I'm going to leave this open to the panel. There is some novel research showing that iron may be essential for malignant cells and may have a role in promoting metastases in cancer. And so the question that's posed is, may we be doing more harm than good at optimising iron prior to surgery?
I suppose at the moment we forget the name of the study that's looking at iron therapy, which was due to report. I mean, for us in Manchester, we're trying to give iron to patients as part of our pathway, and we had that worked out quite successfully for our hospital behind us, MFT. I suppose we're trying to reimagine that at the moment in terms of minimising patient coming into hospitals. So I suppose it's a PREVENT study, isn't it, that was going to look at the outcomes in terms of cancer problems, So I suppose we're waiting for that, Denny, to come through. But at the moment, I think it would be wrong of us not to give intravenous iron whilst we wait for that study.
Yeah.
It's just getting the mechanics of how we do that with one-stop shops, I suppose.
Having looked at the literature surrounding the iron in the malignant cells and metastases, most of that data is for metastatic disease, firstly, and most of that is not at this point in clinical trial data. So there's interest in manipulating iron pathways in oncology treatments. Some of those actually aim to give supernormal doses of iron to cause ferroptosis. So I think what I would say from having seen some of the literature around this is it's early days, and it may well turn out that there is a balance between too much and too little, as there often is, and that the people that we're treating preoperatively are iron deficient and therefore anemic. We're not giving them excessive iron, and we do know that anemia is associated with the worse outcome. But as John says, until we have interventional studies, we're in a slightly grey area, and I think it's something we have to watch very carefully at the moment. Another question that's a lot of interest is about stopping the clock for prehab therapy. Sandy, do you have any thoughts about that?
So, yes, we've been asked a lot by our alliance to comment on this, and I think Mike and I put a statement out saying that there may be circumstances that you can stop the clock or pause the clock, but it needs to be a multidisciplinary agreement between the oncologist, the surgeon, the patient and the CNS. So I think it's probably not the right language to use if we want to try and get this a commissioned service, because there's nervousness around it. We've shown with Westfit you don't need to stop the clock, in the fact that we can get people fit. Whether that translates into a reduced length of stay is still the jury's out. But as far as I know, at a national perspective, there is no appetite to stopping the clock, and it may be detrimental to our ambition to get this as a commissioned service nationally.
And Rachel, if you get patients right at the beginning of the pathway, as you're aiming to do from general practice, do you find there's sufficient time without stopping the clock even to optimise very unfit patients?
Yeah, so certainly the referral to treatment time for cancer pathways is 62 days. So if you get them at the very entry point into that, and obviously using a broad brush approach in terms of health optimisation at the outset, there should be very small need to stop the clock. Having said that, though, patient preference does have to play a part, and with good shared decision making and informing the patient about the changes, the potential outcome, then that has to be, like Sandy says, a shared decision with the patient and the multidisciplinary team. But essentially, starting the process of optimisation at the very outset with the initial referral, then that does have a huge implication in terms of increasing the time for remedial treatment.
So someone's just quickly asked me, what does stop the clock mean? It's a colloquial term that we use often in the United Kingdom, meaning would we delay surgery in order to prehabilitate a patient, so essentially prolonging the preoperative pathway in order to get them fit. So delay surgery to pre-optimise. And John, in your programme, you've seen very impressive changes in fitness. How long does it take to get those changes? How many weeks of training or intervention?
So for us, Denny, we're seeing 25 to 30 days. We can get that time in most pathways by going early, and I think the MDT was giving us that time before obviously COVID hit. So we were crafting that time out of the pathway. I suppose the thing that I would consider is that not everyone needs those weeks of the exercise part of prehab, and it may be that if we could be more selective in who we go for that with, then it might be that we find the group that genuinely need those extra weeks, and people who are fitter, maybe they just need 1 or 2 weeks of preparation, and it might be more psychologically for them, and particularly how they get into recovery. And the way it was working for us is we were trying to push some of those fitter people through, but they got the benefits of understanding what the gym would give them after the operation, rather than what they would need beforehand, and they would go more straight to surgery. So I think, like you mentioned in some of your talks as well, it's getting those frailer patients that really benefit from that period of time, and particularly in colorectal, where the evidence probably isn't there for causing a harm with delay, whereas lung, there is a problem. And I think it does go towards different surgical groups. It's not all the same. So I think it's finding the ones that need it most and then going to the groups and saying, well, making sure we don't do harm, as you've mentioned before. So, yeah, I think within 2 or 3 weeks we've seen reasonably good change.
Yeah. So some consistent themes there. I think one of the issues is access to the patient early in the pathway. If you've traditionally had your pre-assessment or pre-optimisation clinic immediately prior to surgery, you've already missed the window, and it wouldn't be the right thing to delay patients at that point. It should be part of our business as perioperative physicians to identify them and recraft our pathways so that we know about them at the point of contemplation. So opening up that window of opportunity, it sounds like that's really important.
One of the difficulties potentially, Denny, about stop the clock is the evidence around the clock times. That's a completely different discussion, of course, but there may be a re-education process around some of that as we move forwards and gather increasing evidence for prehabilitation.
I think the consistent what people are saying, there's no reason to stop the clock, to delay surgery in the majority of cases. There may be some cases where the risk would outweigh the benefit. It would depend on the underlying cancer and the risks of delaying, and that would be something that would evolve as we have more clear data. There's another question saying, if you put your exercise bike outside, does that change it to a non-aerosol generating procedure? We are allowed to cycle outside in most countries, says Dr. Mike Swart from Torquay. Does anyone want to take on that question, Jerry?
Well, Mike, I suppose it depends how you're feeling, whether you're going to wear a mask or whether you're just cycling around the hospital in your lunch break, a bit of activity. It would be an interesting thought, wouldn't it? PPE fully done up in the car park. I don't think I've got any evidence to back up whether taking it outside would be a good thing or not.
Yeah.
It's the distance you are from the patient, isn't it? And
Absolutely.
how you reduce the risk of the healthcare provider acquiring COVID. So as you talked about earlier on, Denny, with Mike, and the risks around inadvertently giving people COVID, I think we all need to recognise, which we all I'm sure do recognise that, but when we're talking to patients on the phone at the moment, they're really worried about getting COVID in hospital. So I think all the knowledge around we can give them, as much as we can give them in terms of education, stuff that Rachel's doing and the stuff that you're doing with SafeFit, I think that's all building the idea that we're trying to, I think, taking the opportunity to move some of that stuff out of hospitals as well, which it doesn't need to be done in hospital. So we need to take the opportunity, don't we, say, well, can it be done digitally? Can it be done in community? And leave the bits that really need to be done in hospital.
Absolutely. So it's still aerosol generating, but it disperses when you're outside.
Yeah, quicker.
Yeah.
And there's several questions on the same theme about workforce and whether we are using exercise physiologists, physiotherapists, sports and exercise physiologists. Who's the right person to be delivering prehab, I think is what's being asked.
There's no one member that should be taking prehab forward. It's, as I've described it to our directors, it should be a toolbox approach. So in terms of exercise physiology, exercise specialists, personal trainers, and obviously physiotherapy as part of that team, but underpinned by good online digital support as well, because not every patient will need that face-to-face intervention.
I think the other thing is that demedicalising this process as much as possible is a useful thing moving forwards. A lot of us are using community public health gyms and facilities. That's what John's strategy is in Manchester. That's what we're doing in South Tees. And it's building those bridges between the community sectors, the public health services and secondary and primary care. So I agree. I don't think there's any right one person, but I think the more we can make it demedicalised and business as usual, the more likely it is to be successful.
I think it's helpful to add into that the delivery of the prescription versus who actually does the sessions is different. And I think it's very helpful to agree how we do that. We've had benefits from James Steele joining us to give us the credibility of what we're trying to do with the exercise. So it does feel like it's a grown-up approach. But I think we all recognise the benefits of the actual giving of the session in a community-based, using HP colleagues where we can for more high-risk people. But the gyms are so ready to do this, and they so want to do it. And I think the COVID rehab work, all those different work streams fit really well with that, I think.
And there's a couple of questions about safety as well in gyms. People were worried about doing high-intensity exercise interval training in gyms in the community without supervision.
We were concerned about this, I think, because all the patients that are part of Westfit have a cardiopulmonary exercise test beforehand. We've got rigorous screening. Personal trainers, they're fantastic personal trainers. They get it completely. And with our trial team, we've got a very tight SOP that we check that there's no signs or symptoms. The personal trainers are quite competent at being able to pick up if there's any issues, that they contact the trial team. So I can only say, touch wood, so far we've not had any major issues. They do have resource and the facilities there. And we have got 10 gyms open, so I can only really say from experience that's how we've delivered it.
So certainly to date, it looks like it's been safe and feasible to deliver that sort of exercise training in a community environment in public gyms. Another question, maybe this one to John. Should all cancer diagnosis patients, not just surgical patients, be included in prehab?
Really good question. I think that chemotherapy, radiotherapy are waiting for us to get in there alongside those oncological colleagues, and I think they're different groups. And I think when you look at the effects, I know you guys have done lots of work down in Southampton around NAC and other therapies pre and post surgery. But I think when you think about people who are just having that as their main therapy, it's actually a harder process for them to go through than surgery. I think it was a consistent. So I think we need to collectively get into that group of people, support them, and just turn our attention, take the surgical knowledge and move it across to oncological therapies and radiotherapy.
In the United Kingdom, the national guidance is now that patients should self-isolate for 14 days prior to elective surgery. How would this fit in with gym-based programmes? So perhaps somebody would like to answer that.
I think that's a really difficult one to square off, isn't it? Because at the minute, we don't need to worry about that because the gyms haven't reopened anyway. I think that is going to be very difficult. Really, I think supporting people in better ways remotely is likely in the shorter term until those gyms have reopened and we can do things safely in smaller groups. Whether there can be some kind of travel corridor between the house and the gym is another interesting thought.
Yeah, there's been some suggestions with our commercial partners that these hubs that are the rapid diagnostic centres of services that do the diagnostics and the infusion, that they could put prehab in there. And this, I think we need to be more prescriptive and say it's only for the specialist group that really needs that level of intensity and maybe some targeted. So if this was going to be a service, I think we need to be much more, we need to triage more effectively.
Another question from Slido, talking about the potential of causing harm with inappropriate exercise regimes with weight loss in patients in a catabolic state.
From a nutrition perspective, with SafeFit, I'm one of the nutrition advisors for SafeFit, because one of the concerns was obviously about blanket delivery of exercise when patients are potentially, like you say, catabolic, stressed, and obviously at risk of continuing weight loss. Rigor has gone into that using nutrition screening tools. We use nutrition assessment tools. One is called the PGSGA, and it's patient guided. And early results from SafeFit suggest that it's not a huge concern. That's because we've addressed it. And again, it must be seen as your nutrition needs to be addressed, as you say, Danny, in terms of the multimodal approach. And one size does not fit all.
There's a question that I wanted to ask. I might just jump to the top of Slido from watching all the talks. Was the difference in adherence levels between some of the programmes that you've reported, and so these are in prehab programmes, in particular, whether there's a difference in the teachable moment for cancer patients and non-cancer patients, because that was one of the obvious differences between PrepWell, for example, where you have less patients volunteering, whereas in the Manchester Cancer, there were a lot more patients. Have you got any thoughts about why it might be?
You're right, Denny. When you tell someone they've got cancer, it's a life-changing event, isn't it? And I think at that point they are listening to healthcare more than they've probably ever done before. So I think for us, getting people into the system, that really worked, although up to 20% of patients still, even though they heard about prehab, didn't want to do it for whatever reason. So, but once they're in, 90%, 95% plus would stay within the programme, so they felt it was good. So what we're trying to understand is why did that 20% not want to take part, so we can take that forward and understand for patients. And it may be that they don't want to be with other people and the digital option may be something for them. I think COVID will reimagine how they view health. And I think we'll see differences now that people, when you say to them, actually, you're going to have surgery, even if it's benign non-cancer surgery, but this will help you improve your health going forward. I think more people will take up these ideas, I think.
It's a bit like reporting deaths and excess deaths in different countries from COVID and the nuances around, why things appear different. So, for example, the opportunity in Manchester, how many gyms have you got open, John?
80 gyms, yeah.
Yeah, so you've got, everybody's within 5 minutes of home or whatever, and I think that's a hugely important factor. And to date, we haven't had the luxury of that model with more limited access to facilities in a certain location. And because in South Tees we're a tertiary, fairly rural area with fairly large travelling times, if you look at the breakdown of, there's a difference between adherence and uptake, and actually our adherence once people in the programme was pretty good. It was about 74%, whereas the uptake was around 50%. And the majority of the reasons for lack of uptake were around either not interested, travel distance, or work commitments. And I think that does show that as we move forwards, we have to be more flexible in our range of options that we make available, because when you ask people, and we kind of published on this, not everybody is interested in doing either community or hospital-based prehab. There is a big appetite for a home-based opportunity even before the current situation hit. Around 1 in 4 patients, 1 in 3 to 1 in 4 people preferred a home-based option. There's a lot of factors to take into account when you look at these uptakes and adherences, I think.
Just to add to that, I think with the COVID pandemic, it's certainly normalised online exercise programs as well, through households with Joe Wicks and a huge plethora of online content. And I think we've got to jump on that horse now and build on that, because realistically, to embed the prehab principles for every single patient with cancer and or surgery across the UK with a targeted approach is going to be completely not affordable potentially in the short term. It may pay off in the long term as we do some mathematical modelling in terms of economics. It's about that toolbox I referred to. I think we have to have a different approach and different sort of strategies, really.
Predominantly, the restrictions or limitations to people taking part in Westfit was distance travel on time. And as we open more gyms across Wessex, then our uptake significantly improved. I agree. I think it is a very sad time, but it's an opportunity to maybe rethink how prehab could be delivered. And we, as I say, we need to very effectively screen and assess so that we deliver the right interventions to the right people at the right time.
A question that's been put forward by a number of people is about advice on bridging the gap between pre-assessment and prehabilitation.
The way we're trying to address that locally is by building a kind of digital dashboard and tracking system, so that the patients who are coming into prehab will have the relevant health-related and quality of life questionnaires sent to them at home if they're digitally enabled. There's still some work to go through from there, but then that data, if we use the same systems, can be extrapolated into, 80% can be retrieved within the pre-assessment process. So it's leaner for patients. They don't have to answer the same questions repeatedly, but that all has to revolve around using the same systems and getting them to talk to each other. And that's the way that we're presently trying to bridge that gap between prehab and pre-assessment, so that the lifestyle behaviours, the quality of life questionnaires, the assessments done at prehab are immediately available, and we can communicate with our pre-assessment colleagues down the track.
There is a question here about prehab in Scotland. Has anybody got any experience of any centres that are in Scotland? They were asking specifically about prehab centres in Scotland and funding available in Scotland?
We were invited this time last year to travel up to Scotland and share experiences, and obviously the sharing came back from the Scottish Government perspective. I know David MacDonald, who also oversees the Enhanced Recovery Programmes, is working tirelessly behind the scenes to try and get prehab programmes set up nationally. And the other person to contact David MacDonald in Scottish Government, and the other person would be somebody called Debbie Proven, who's a dietitian, Macmillan dietitian, who again is, I know there was a questionnaire, a survey done of all the health institutions in Scotland as to the baseline assessment for prehab. So I think there's work going on. I would urge you to make contact with David, and apologies to David in advance, but I think it's welcome support.
Okay, thanks ever so much. I think we're going to bring the session to a close there.
Top Med Talk. Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.